यस सर. हाँ जी ठीक सब ठीक है.
Good evening, everyone. I hope everyone can hear me. Dr. Ravi Mahajan, Dr. Khazanchi, I hope. Let us check if you are audible.
बुखार है क्या? खास? ठीक है, okay.
Dr. Khazanchi, can you just say a hey in your mic and we can check if you're audible?
Hello.
No, sir, you're not audible. Could you please check your mic?
Mic, let me see. Yeah.
Malika is audible to me.
Yeah. Can you hear me now?
Yes, sir, I can hear you. I think it was a connection issue on my end. I'm very sorry. I hope everyone is audible now. And we are very sorry for all the technical issues which led to the delay in the meeting. And first of all, thank you so much, everyone, for joining us. And it's a pleasure to have all of you here. But before we begin this meeting, I hope you all know the general rules. I would like to again repeat them. So guys, welcome everyone to the second keynote of AMSACON. General rules for all of you, you know the drill, but still, apart from the speakers, I request everyone else to keep their videos off, to keep their mics on mute, as well as please don't share your screens and do not chat in the chat box until and unless it's a doubt. So keeping all these rules in mind, I repeat, please keep your videos off, except for the speakers. Please keep your mics on mute, except for the speakers, and do not chat and do not share your screen again, except for the speakers, or until unless you have a doubt, you can put it in the chat box. All the co-hosts can address them anytime. So with this note, on a very high note, on a very good note, I would like to begin today's keynote. And I am honored to be the host for today's keynote. I am Malika Gupta, the Secretary of Marketing and Sponsorship for AMSA India. It is my privilege to host today's keynote, the second keynote of AMSACON, and the AMSA team, the AMSACON team is honored to have two esteemed leaders of plastic surgery in India, Dr. R.K. Khazanchi and Dr. Ravi Mahajan among us, who have taken time out of their very busy schedules to help us learn more about plastic surgery. Guys, we have been given a very fortunate upper hand to know what is plastic surgery. So let us make sure we take a good hold of this golden opportunity. Giving a very short intro on our two speakers, on the two esteemed leaders who have joined us today. We have Dr. R.K. Khazanchi, who is the president of the Association of Plastic Surgeons of India, and he currently is the chairman of Plastic, Aesthetic, and the Reconstructive Surgery at Medanta Group of Hospitals in Gurugram. Also, we have Dr. Ravi Mahajan, who's the president-elect of the Association of Plastic Surgeons of India and the current president of Indian Society of Reconstructive Microsurgery. He is the chairman of Plastic, Aesthetic, and Reconstructive Surgery at Amandeep Groups of Hospital in Amritsar. Dr. R.K. Khazanchi and Dr. Ravi Mahajan, we are honored to have you among us. So again, sir, taking this time, just to begin this keynote before handing you the mic, I would just like to begin by saying that every layman, me as well, and every student before they join the medical schools have this notion in the mind, what they think about plastic surgery. Before I joined the medical school, when I was just a student, when I was a layman in normal terms, I thought of plastic surgery as what I saw in the dramas, what I saw in the tabloids, what I saw on the TV, like some actress got suddenly very pretty and they say plastic surgery was the one which helped her. Plastic surgery for me was always a branch of surgery which was always attached with cosmesis. you realize that layman always think of plastic surgery as a branch which can enhance everybody's beauty. It can make me as Aishwarya Rai. The plastic surgery is a magical branch related with cosmesis. But now that I have come in the medical school, now that I go for my clinics, and I think even now my knowledge is very less, but now that we go to the medical school, we know that plastic surgery is so way beyond that. So I think now handing you the mic and now giving the stage to you, to Dr. Ravi Mahajan, Dr. A.K. Khazanchi, I would like to take this opportunity to learn more about what exactly plastic surgery is. So if Dr. Khazanchi and Dr. Mahajan are sharing the screen, just allow me, I'll allow them to share your screen. So sir, the stage is all yours.
So who's going first, Ravi or me?
Yeah, Dr. Khazanchi, I think you are going to talk first.
Okay.
Dr. Khazanchi, you are going to talk first and I will follow you.
Right. Okay. So I'm going to put my screen share on. Okay. So just tell me that are you seeing a PowerPoint now?
Yes, sir.
Yes, sir, we can.
Okay. So thank you, Ms. Gupta, for this rather flattering introduction. First of all, yes, what you said was right, that most of the time people think that plastic surgery is all about beautifying people. Yes, to a major extent it is true, but also to a major extent there is a lot more to plastic surgery than just beautifying people. Also, there are these myths attached to plastic surgery that it's only for the rich, they don't use any stitches, and that it's got something to do with plastic. And, there's these kind of jokes that people will say, okay, how much, doctor, how much will it cost? So you say, well, it costs about, say, 100,000 rupees. He says, well, I'll bring my own plastic. It's much cheaper for me. So can you make it cheaper? So we get sent jokes like that. And in fact, one of our colleagues, his plastic surgery nursing home was raided by the Delhi authorities. They thought there was a plastic being manufactured there, and it was not permitted to be manufactured in the residential area. It's a true incident. His house was raided with this notion. And of course, then the movies show that, Aishwarya Rai becomes whoever, Zeenat Aman or XYZ. And again, that creates a lot of myths. So today we'll be clarifying some of those myths that you have, but at the same time, since most of you think that plastic surgery has something to do with cosmetic surgery, I'm going to start with cosmetic surgery. However, if I give you an overview of the procedures, besides cosmetic surgery, plastic surgery has cancer reconstruction, nerve surgery, trauma, burns, congenital defects, and also some non-surgical body rejuvenation that we do. So between Ravi and myself, we have divided this talk into two parts. I will cover the first three parts, and that is the cosmetic surgery, cancer reconstruction, nerve surgery, and some very recent advances in plastic surgery towards the end, and Ravi will cover the rest. Let me be honest, it's very difficult to cover the entire gamut of plastic surgery within the hour, but given the time restraints, we will touch on very important and really recent advances in plastic surgery. So I'm going to start with cosmetic surgery. So cosmetic surgery is something where you have people who are otherwise normal, there's nothing wrong with them, but something within their body they may not like. They may be at any age. Here is an old lady. She thinks that her face makes her look older than what she is, and she would like some improvement there. So, and then what needs to be done in this case, traditionally it is called facelift. She has a problem with the face, her eyes are a little baggy, she looks a little tired, the neck is hanging down. So we do an operation, what is called facelift. That means doing a surgery through incisions right in front of the ear. And then we also address her eyelids, which are, you can see they are droopy, they look better here. So this is a pre and post-op result of a patient with facelift, as well as blepharoplasty and also a neck lift. You can see her neck kind of hanging down, and after the operation, it's been lifted to a nicer contour. So she looks younger than what she was when she came to us. So this is a an operation which is not very commonly done because Indian skin doesn't age that much, but we do get some patients from overseas and also some from India. And here is another patient who had a facelift. And she also, you see her eyebrows are down and we need to pull them up. So eyebrow lift, forehead lift, as well as neck surgery. And she also had along with that a rhinoplasty. Now this is a patient who looks, again, she's just about 45 or 50, but she looks older than her age. There's a lot of sun damage to the skin. So this is what she looks like after a facelift, again, blepharoplasty, but she also had an added laser resurfacing of her skin on the face. So it has a younger appearance. So for the sake of identity, we have to hide her eyes. And then we go on to just eye bag surgery. A lot of people have these, eye bags, and they look kind of, they have a tired look because of these eye bags. So this is again a surgery done through an incision, either in the conjunctiva or at the margin of the eyelashes, and you can't make out the scar, and this gives them a younger look. So this is blepharoplasty, another patient with a four-lid blepharoplasty done. Then we have children, going to another age. This is a child with bat ears, and obviously he gets teased in the school, and this is a bat ear correction. That is a reasonably common operation with us. The most common operation that we do is a nose job, what you call a nose job, or what we technically call a rhinoplasty. So this is kind of, I will call it a very Indian nose, with the skin is very thick, it's pudgy looking, it's a little flatter, and this requires a surgery by which we expose the nasal skin, go under the skin, and we remove this little soft tissue which is giving her this pudginess in the nose, and then reshape the articles. You see that extra tissue, we are going to remove that, and then the cartilages will be reshaped into normal shape, and the only incision that you have outside on the skin is at the base of the columella, and once you stitch that, you cannot see that incision. So we'll show you some pre and post-op pictures of patients who had a nose job done. You can see the nose here and the post-op, and you see here how the nose looks a little wide and the tip is not very good, and it has improved here. So just sharing some more results of rhinoplasty with you. This is all before and after. And then another one, she not only had just rhinoplasty, she also had some fat injection on the face to make it look better, some scar revision. And these people who are not very confident when they begin with, they are introverts. You can see her, after the operation, when she came to see me, she was a totally changed person. One could not recognize. This was the kind of self-confidence that she gained. So a lot of reason to do cosmetic surgeries, for not just to make them look good, to make them feel better. It's a feel-good operation. And a young boy who aspiring to be a model wasn't happy with the nose, and you can see this is pre and post. So another one, you see this nose, the middle part is hanging down, and this is corrected and makes a lot of difference to the appearance. So keep going. A flattish nose, augmentation rhinoplasty. Now going ahead, this lady had not just the nose problem, but her chin was also small. You can see that here. And then when we did the operation, we also put an implant on the chin to make her chin improved. And you see this is pre and post, and you see the kind of difference in their outlook that changes with the gain in confidence. Okay, this is another young aspiring model, and initially she said her face was very wide, so we removed what is called the buccal fat pad and made it a little narrow. She was still not happy, and then we second surgery where we fixed the nose, did a rhinoplasty, and also removed more buccal fat pad and removed some fat from under the chin, and you can see her face has improved from an oval face to a triangular face. This is a condition called Binder syndrome. The nose is flat, there is hypoplasia in the nasomaxillary region, and here we put grafts. We use cartilage grafts to improve this. What you see here is before and after. The nose is lifted up, and this dorsum, which was not good, has improved. And we also put some implants in this region to make this part look fuller than what it is. So it's not just nose correction, but a total correction. Another patient, not just rhinoplasty, it's rhinoplasty, slight reduction of the malar prominences, chin augmentation. So these three things done together. So that is how we make her, give her improved and a better look and more confidence. We now move on to cosmetic surgery of the breast. So commonly asked in younger people, and also sometimes people who are post-lactational atrophy of the breast, they ask for augmentation. I would request any listeners or participants, if there are going to be some graphic pictures. So if there are any children or people hanging around who should not be there, you may please ask them to leave. Okay, so another one, again, this is breast augmentation done through an incision under the skin crease here, so you can't make out where it is. It can also be done through a periareolar incision. So this is pre and post of a patient who has augmentation breast surgery. Then we have people who want for either a reduction or sometimes no reduction is required, only a lifting is required. So here is a reduction with lifting. This is pre and post. And here is another slightly bigger breast. Again, reduction and lifting. You can see we have reduced almost 1 kilo and 100 grams from the breast, and it's a weight reduction as well as improved shape. And this is again a young girl who had a reduction of almost 3 kilos from both the breasts, and this is before and after picture. Another one, this is predominantly what is called a mastopexy with very little reduction, and this is again before and after. Going for the same patient, you can see the result after about 2 years, the result has maintained itself. Then we get patients' male breasts. This is a common problem with adolescents today. They get locker room problems, they get gait problems because they try and hide their chest and have a bent sort of forward bending walk. So this is a simple operation, liposuction with subcutaneous breast, removal of the breast tissue. It's done through a small incision just at the nipple areola skin line. So you don't see any scars, and it's a very gratifying result for patients who get it done. So this is another one of the same. Then we move on to the cosmetic surgery of the abdomen. Again, common post-pregnancy, there is, laxity of the abdominal wall. So we're going to remove this much of skin here. And when we remove that, we bring the top skin down. The scar is in the lower part. Scar is hidden under the undergarments, and you don't see the scar. The umbilicus goes to a new position. We even make the shape of the umbilicus very well. We create a little crease here. What is the little depression here, and also depressions here. So it gives the appearance of a young flat abdomen. And this is operation which is done in post-pregnancy abdominal flattening. And also this is a similar picture, but a bigger problem, and the same operation, which is abdominoplasty. Sometimes abdominoplasty has to be combined with liposuction as well. That means this is a bigger, fatter abdomen. So we're going to do liposuction in this part. We're going to remove the skin here, and this is the post-op result of the same patient. Okay, and then we have now, as we go, more and more advances are there. We don't do just lipoabdominoplasty. Here is a patient who doesn't want just abdomen shaped, but wants all these little, handles, extra fat bulges taken care of. So all this marking is done as a part of the planning to where we're going to remove the fat, where we're going to remove the skin. And this is the pre-op, and this is the actual planning, and this is the post-op picture here. And same thing you see here, that this is the pre-op marking, and this is the post-op. You see from the back, see all these extra folds here have all disappeared. This is done by liposuction. So this has to be done, improving the contour of back, flanks. So this is something that gives them a very gratifying result. So going even further, now this patient was in her, late 40s or early 50s. She wanted everything done. She wanted her breast lifted up. She wanted her, tummy tuck done. And she also had some extra skin, loose skin in the thigh, which was following weight loss. So she wanted that corrected. So this was the amount of skin removed from her tummy. This is removed from the thighs. And this is the mastopexy, augmentation mastopexy markings. And what you see here is the same patient. You see the thigh contour is better, the abdomen is better, and she has a breast lift as well as an augmentation. So this is what we call the It's like mommy makeover. It's a total makeover of this person. Then you have patients who undergo liposuction. This is the amount of fat that you can remove or even more, depending on what you need to remove. This is an arm liposuction, hanging skin folds with extra fat, pre and post. And then we have this male liposuction, because you can see here that this is bulging here and this person is not happy with that. So we've taken care of that. Similarly, liposuction for the saddlebags here, for the thigh. So this is pre and post to improve the contour of the waist as well as decrease the size of the thighs. We also get patients now who have massive weight loss, and they have, this kind of after weight loss. So we do what is called a belt lipectomy. The entire circumferential part is removed. This is again before markings and after. Once again on the side before marking and after. Another patient, this patient had lost 80 kilos of weight, and you see the kind of weight skin folds that she had. Again, pre-op, and this is post-op. From the back, pre-op and post-op. And this is close-up of the back, and you see all these things pre and post. So we now move on to cancer reconstruction. I think I'm taken about 15 minutes. I'm going to take another 15 minutes for this. So most common cancer in India is oral cancer. And in oral cancer, when you do surgery, you have to remove, sometimes it's only the lining, but very often it may be mouth lining, the skin, as well as the jawbone. So we have to reconstruct not just lining, skin, bone, and sometimes the nerves, like sensory nerve is removed here, a mental nerve will be removed, and sometimes muscles are removed. All these have to be reconstructed. So we have wherewithal to tailor our reconstruction to whatever is required. For example, in this case, the mandible part was intact. So we only have to reconstruct the skin outside as well as inside. So this is outside, inside. I won't go into the details of surgery. This is for outside, this is for inside, and the fat is to fill up all the gaps. And this is the patient, same patient, you see all removed. And this is what he looks post-op. So this is free flap surgery. And this patient had a cancer in the tongue. So after the surgeon had removed it, he lost most of his, almost more than 2/3 of the front part of the tongue. So unless we do a good reconstruction, he will not be able to eat or speak. So here we have to plan this reconstruction very carefully. I'll tell you how. So we make this skin, and from the skin we made a tongue, and we've made the floor of the mouth here. And then we also take some muscle to reconstruct the muscle of the tongue. And to neurotize the muscle, so this is the actual removed specimen, and this is the tongue that we are going to make. And this is the vascular pedicle, artery and vein. And we have a nerve here, which is the motor nerve to this muscle. We are going to connect it through the motor nerve to the tongue, that is the hypoglossal nerve, so that this becomes mobile. So this is the patient, the early part of reconstruction, late. And this is, so he's still able to speak while he's lost most of his tongue. He's able to speak. Sorry, I'm not, because we don't have enough time, I have to rush through. And sometimes, as we said, that we cut sensory nerves, and then we put nerve grafts to reconstruct the sensory nerve. You can see here a nerve graft has been put so that they can regain sensations on the face. When mandible is reconstructed, this is the sensory nerve reconstruction, which is showing the mental nerve going into the chin skin. And when mandible is reconstructed, mandible is removed, we have to reconstruct it we use computer-aided design and computer-aided manufacture process to make a new mandible from the fibula. Earlier, we used to do it by rough guessing, but with computer technology, we can precisely plan what is going to be removed and how we are going to make the cuts on the fibula, so that these cuts, once we join it together, they replicate the mandible exactly what we have removed. So you see, we plan the cuts, then the guides are 3D printed, and these guides are used to make the cuts exactly as we had done in virtual surgical planning. And then this is for the fibula. Again, cutting guides are there. You see cutting guides placed on fibula. And when we do the reconstruction, this is a pre-op patient with oral cancer with mandible to be removed. You see here the mandible has been removed, the skin has been removed. So this is the fibula with skin for inside, skin for outside, and the fibula angles have been converted to become a mandible. This is the ascending ramus, and you see pre and post the patient. You at the mandibular contour, you cannot make out that he's without his jawbone. And you see the X-ray here, same thing. The X-ray shows these are the actual mini plates that are used to fix the mandible. So not only we can make the mandible, we can also put dental implants. So these are the receptacles for the dental implants which are put in at that time. You see, as we have reconstructed the mandible, we've also provided him with teeth. So this is a complete mandibular and dental rehabilitation. So this planning is also done by using computer-aided manufacture and design. And you see the actual planning here and the actual doing that operation, how it looks on the X-ray. And this is the same patient. Barring the little thing, deformity in the neck, you cannot tell here which is pre-op and which is post-op. And he had a major cancer of his left buccal mucosa resected. So similarly, large amounts of muscle have been removed, and the muscle has to be reconstructed. Some slings are used so that this angle doesn't droop down. So this is before and after another cancer reconstruction. So I think time is short. This is another cancer reconstruction outside and inside. And we put in some muscle inside to fill up all the dead spaces so that he doesn't get a depression there. Going further on breast reconstruction, again, breast cancer is a common cancer in women in our country. And this is right breast cancer, sorry, left side breast cancer. And you see this is early post-op reconstruction. And this is later where we have done the reconstruction of nipple areola complex also. And with the good quality of reconstruction, this is a very good operation for women who have breast cancer. Another one where the secondary reconstruction was done. This is before, and this is the reconstruction of the right breast along with nipple areola complex. And we have also reduced the left breast so that it has a better match with the reconstructed breast. And this is a patient who had a nipple-sparing bilateral mastectomy. You know, this is the incision for the nipple-sparing mastectomy. And we use the spare abdominal skin, you know, from here. You see that skin. We will take all that skin, patient gets a tummy tuck, and also the breast reconstruction is done. These are the incisions for the nipple-sparing mastectomy. And you see a good bilateral reconstruction. And barring the operative scar, there is nothing else to tell that she's had her breast removed. We also see patients with soft tissue tumors. There is a patient with a aggressive fibromatosis, which was involving the arteries. You can see that, nerves, tendons. So it's a complete resection of the tumor. And we do nerve reconstruction, tendon reconstruction, and also a flow-through flap. That means we have to restore the circulation to the hand also. So all this is pre and post, and patient has regained function, as well as, you know, a hand has been saved. Otherwise, in the past, we will have to do amputations for such operations. I won't again go into the detail. Brachial plexus injuries and peripheral nerve surgery is another area that we reconstruct. This is, you know, brachial plexus is something medical students find very difficult. But we have various operations like nerve repairs, nerve transfers. Sometimes we use spinal accessory nerve, phrenic nerve, intercostal nerve to neurotize muscles which have been lost, function is lost because of a brachial plexus injury. So sometimes we even use opposite side, you know, C7 part of that and bring it to the side of injury, so take it from the normal side. This is the various pictures of nerve repairs. I don't have time to go into details, but this is just to give you an introduction. Then we have facial nerve injuries. It's again a special area other than, of course, all the other peripheral nerves. Sometimes we do in patients what is called a cross facial nerve graft. This patient has a paralysis on the right side, and we use a normal nerve from the right side and connect it to the nerves. We use a branch, don't use the whole nerve, so that part is functional, and connect it to the other side. Or sometimes we also have the option of using the anterior branch of the mesenteric nerve, a nerve which supplies the mesenteric muscle, and connect it to the facial nerve. So you see here it is pre-op, no movement here. And you see here post-op, he's able to, his position, he's able to move. You can see that now. So some amount of motor re-education is required. This was a cross-facial nerve graft. And here pre-op, no movement. Post-op, you can see the movement. This is a mesenteric nerve transfer. Again, pre-op, no movement here. Post-op, you can see she's able to move her angle. And this is a smile restoration. Another patient, pre-op, but again, here the eye also has been operated by a temporalis muscle transfer to get eye closure. No closure here, you get eye closure. And same thing with the lip. He's able to move his lips and he's able to smile. Right. So my last section, I'll be taking another 5 minutes, is to use again CAD/CAM technology in other reconstructions. This is a patient, you can see is a big chin. If you see his face from the side, he looks very elongated face. So we plan this operation, how much reduction has to be done. What do we need to do here is to advance his maxilla, push his mandible back, and also push his chin back a little bit. And then this is just virtually how this operation is done. It'll take just less than a minute. So this is how the planning of the operation is. And just play the video. Okay. So there we remove parts of the mandible, push the mandible back, bring them, see, that is to push the mandible back, bring the maxilla forward, then fix it with some plates. And similarly, this is pre and post of the same patient, and I'll actually show you the actual patient. Now this is the patient, this is pre-op pictures, and then this is the post-op picture. We brought his maxilla forward, pushed his mandible back, and he's a whole new person. And again, this is the side view, pre and post. You see, he's a totally changed person. I think these are very confidence-gaining operations. And you see, this is before the operation, but you can see a lot of hardware has been used to fix all those bones. You know, these are the plates, and these are arch bars. Another patient with a chin problem, with asymmetry, and again a virtual planning. We see how we want her to look like this. So we plan a cut here and shift this segment of bone across to the right side. And you see here, both are pre-op pictures. Now you see how much difference it makes to her appearance. It's totally changed appearance. This girl had no chin because of her TM joint ankylosis. So her chin was small because mandible had not grown. So what we do here is plan what is called a distraction. We're going to elongate her mandible by using distractors. This is you can see her teeth are also not in proper occlusion. And this is the planning on 3D, how much we have to distract. We have to bring the jaw down and forwards. And this is done by using special distractors. I'm going to show you the distractor here. You see this here, the distractors are here, and you can rotate these screws, and this brings it apart. It can do distraction in 2 planes. And this is the X-ray. While the distraction was in progress, you can see the gap that we have created here. And then we have to give it time for that bone to heal. So this is this is after the distraction. And then another genioplasty, that means the chin was advanced by using bony advancement here. And this is what she looks like now. And you see the side view in the same. This is her final appearance. This is a totally changed person. Another CAD/CAM technology application, she had an asymmetry of the face because of the depression in the forehead. You see that on the skull X-ray, you see this depression. And what we do here, what is called rapid prototyping, that is, we superimpose the normal side onto the abnormal side. And then by doing that, we say that we need an implant which looks like this to make this equal. And then we make a negative of this implant. This negative is used to manufacture the implant during the operation. So you have a precise manufacture of implant. Pre and post, the depression is gone. And again, from the side, you see, and you see here, this is the difference that it makes to the patient. Similarly, post-traumatic, this patient had multiple fractures treated elsewhere. There was a depressed area on the forehead. The bone had fractured and gone down. And because she came to us late, we cannot bring it back. So we have to then plan an implant to make it. So we plan an implant. So this is the planned implant here. On this goes here and onto the zygoma. And you see, this is what she was before the accident. This is what when she came to us. and following implant, this is what she looks like. So we have brought her, closer to what her look was before the operation. And this is the last case in my computer-aided series, a very complicated case. He had a tumor involving the maxilla and the zygoma, and you can see that whole tumor. And his virtual planning involved a resection which would look like this. We would take out half of the bones of his face on this side, the maxilla, the zygoma, the floor of the orbit, and whatever bones are there in the floor of the orbit. The plan here, why call it hybrid reconstruction? We'll make the jaw with the fibula, and we'll make the rest of the facial bones with an implant. So this is an implant which we manufacture with polymethyl methacrylate. This is fibula, and you see here the actual implant that was used in two parts. So we have to use plates to fix it. And this is the skin which will go into his palate to plug the hole in the palate. This will plug the hole in the nose. And this is the bone that will give him the upper jaw. During the operation, the fibula and the implant in place. And this is before and after. Once again, other than this scar, that is, most of the scar is hidden here. It's along the nose, here, and the midline. You can't make out that he had such a big tumor resected. And only other telltale sign is because he would have had a big hole in the palate. So this is the skin which is covering that hole in the palate. Another case that I would like to share with you is this is the tissue expansion that we use. So this was a child. When I saw her, she was about 1.5 years old. And she had this big hairy nevus on the whole face, was left side of her face as well as scalp was involved. So we use what is called tissue. We put expanders in the normal skin and then remove this and use the expanded skin to cover that. So this, in her case, had to be done not one session, but 3 sessions were done. And in 3 sessions, this is what she was. When she came to us, we were able to remove the entire lesion from the face as well as from the skin. She is now about 13, 14-year-old girl, very pretty girl, and doing very well. So you see the face, the whole thing is removed, and also from the scalp. And some scars are there. These are hidden in the hairline. And I think these scars are also going to be further improved with time. So I think I may have overshot by about 5 minutes. I'm sorry about that. So I think I'll pass on my mic to Ravi now, and we can handle any questions at the end of the talk. Thank you very much.
Thanks a lot, sir. That was really an enlightening session. Now, let's move forward with the presentation by Dr. Ravi Mahajan.
Thank you so much, Dr. Khazanchi, for that really hard work we could see in the presentation you've put. And I think my doubts about the plastic surgery has really been cleared about so far. Dr. Ravi Mahajan, now the stage is yours, and we have very high hopes from you.
Yeah, can you hear me now?
Yes, sir, we can hear you.
Okay. And can you see my screen as well?
Yes, sir, we can.
Okay. So good evening, everybody. So I think we had a very fascinating talk from Dr. Khazanchi, and he has covered most of the cosmetic surgery part, as well as yeah, so as we know now that the plastic surgery, primarily consists of 2 parts. One is the reconstructive surgery, and the next one is the aesthetic surgery. And in reconstructive surgery, I think partly he has covered. So I will be primarily covering the reconstructive surgery part, whatever has not been covered, whereas aesthetic surgery has also has already been covered by Dr. Khazanchi. So I'll be primarily covering the reconstruction of the post-traumatic wounds and deformities, congenital deformities, post-burn deformities, and cancer surgery has also been covered earlier. So as far as the reconstructive surgery is concerned, so I must say that microvascular surgery has really revolutionized the plastic and reconstructive surgery, and it provides the cutting edge to the modern day plastic surgeons for reconstructing different parts of the body. Earlier, we had a lot of conventional methods of reconstructing, but with the advent of microvascular surgery, I think the situation is completely changed, and you will see that. So as you would have noticed that the plastic surgeon doesn't have any specific area of the body to deal with. So we deal with all parts of the body, starting from head to toe. And so I'll start with the head and neck region, and the uppermost part is scalp, as you know. And if you, this is a patient who had the scalp avulsion because of his long hair getting caught in a quarter cutting machine belt, and this was totally taken off. Before the advent of microvascular surgery, we didn't have any option except to put a skin graft here. So there was no way that we could replace this hair-bearing skin by taking the tissue from anywhere else. But now, because of the microvascular surgery, we just had to anastomose one superficial temporal artery and one superficial temporal vein, and we were able to give this man, totally normal as it would have been. And this is how, we were doing when the microvascular surgery was not done. And you can see that how bad it looks. And then it's not only, grotesque looking, but it is also, giving a very unstable area and the recurrent wounds to this patient later on. Similarly, if you have, something like this was a gunshot injury with a very large amount of soft tissue plus as well as the bone. So bone we could reconstruct with a small bone graft, but then the area which we required, both providing lining as well as the cover. So we needed to replace the mucosa as well as the skin also. And so we used a very large radial forearm flap, and which was based on the radial vessels. And the cephalic vein was also used, which was anastomosed to the facial artery here and the veins here. And we could replace this whole tissue with the radial forearm flap inside as well as the outside. And this is what we had at the end. And with some, secondary surgeries, we will be able to provide them almost a near normal appearance, as well as the jaw reconstruction has also been done. And as Dr. Khazanchi has already shown that with the CAD/CAM technology, we can reconstruct the mandible as well as the maxilla in post-cancer cases. So same way it can be done for the post-traumatic defects also. Like this child, had a very major injury, but fortunately the soft tissue was quite adequate and we could repair the soft tissue defect. But the part of the maxilla that was gone, which was reconstructed using again the CAD/CAM technology and the vascularized fibula. And these are the cutting guides, for doing the osteotomies, so that we could make the maxillary alveolus here. And now he is ready for the implants, dental implants. They can be used, and he will be made from this to has been made from this to this totally normal, and he will have going to have the near normal teeth as well. So maxillofacial trauma is another area which is dealt with by the plastic surgeons, and this is a patient of pan-maxillofacial trauma, and you can see that all his bones in the this nasoethmoid region and the region of the maxilla and zygoma, they are all badly, comminuted fractures, and there is a fracture of the mandible as well. And all these fractures, they were fixed with plates through already existing, the wounds, as well as by giving more incisions. Bone grafting was also done. But in spite of that, this is how we had him. We had restored him to much better than what he was at the time of trauma, but still he was having a lot of depression here, and there was a lot of asymmetry of the eyes also. So we then further did the fat grafting in order to make him look normal. So you can see that how it was earlier, and then how he was after we had done all the open reduction, internal fixation of all the fractures, and this is how it was after fat grafting. So as a plastic surgeons, we can not only fix the bones in cases of maxillofacial trauma, but we can take care of a lot of residual deformities by adding on the other plastic surgery techniques. Now, coming to the post-traumatic wound tissue loss or the deformities in the extremities, Again, here the microvascular surgery plays a very important role, and you would agree with me that amputation is probably the worst form of injury one can have in case of a limb, and reimplantation is the best form of reconstruction, and microvascular surgery has made it possible, as you can see in this particular patient. After we did the microvascular surgery, he underwent a lot of physiotherapy, and at the end of the day, the function was also totally restored. And the same way, this young man, had a amputation at the above elbow level. And since he came to us well within time, because in a proximal level amputation, it is very important to reach a microvascular surgery center in less than about 4 to 5 hours, so that we can start the circulation in about 6 hours, and then you can make them, these limbs quite functional. So you can see some of these other patients, who had a total amputation of the hand. And in these cases, we don't only have to join the vessels, you have to join each and everything. So after the bones have been joined, you have to join all the tendons, all the arteries, veins, as well as the nerves, so that the function can be restored to near normal. And these are some of the patients where, the total amputation was there, and after implantation, the function was completely restored. And this is a case of thumb. You will agree with me that thumb is almost 40% of the function of the hand that is carried out by thumb. And this was a third-year medical student, actually, who was assaulted by some people, and he had an amputation of the thumb as well as the injury to the index finger. And there were no veins available on the dorsum. So in this case, we joined one of the digital arteries under a microscope in order to provide the circulation to the thumb. And then the other artery was used to drain the blood out of the thumb, with a proximal part of the dorsal vein. And we also did one, the volar vein also. And now actually he is already doing his post-graduation in one of the surgical specialties, and he's able to do all the surgical work, as well as he's able to write very well. So similarly, the index finger is also very important for writing. And she was a 11-year-old student, who had this injury to the index finger. And then I just met her after about 8 years, and this is the way, she could write. She can write almost near in a normal fashion. And she was very happy, and was, in her 12th standard at that time, and was preparing for NEET examination. And this is a 4.5-year-old child. And in our part of the country, in Punjab, it's very common to see these what are called as tofa injuries. This is a fodder cutting machine. When the children start playing with this machine, and they will end up with the amputation. And this child has the amputation of the thumb as well as the index finger, and we were able to put these back, using microsurgical techniques, and had a very good function. But then many times, you will get a patient like this, where the amputated part has been cut into multiple, smaller parts, and it's not possible to put these small parts back in reimplantation. So she was a young unmarried girl. So initially we just covered it with a flap taken from the groin, and then later on 2 toes were taken from her foot, and then these 2 toes were put over here. And the thumb was lengthened by using this distraction technique. And you can see that now she can write very well. And then she got, actually this probably video is not showing, and she got married, and she's able to do all the domestic work with this hand, where these 2 toes taken from her foot are very useful in addition to the lengthened thumb. So same way, particularly if you have a clean-cut amputation of the leg or the foot, and they are brought to you well within time, so you can put these back. And this was just a 7-year-old male child, and we were able to put this foot back, and he was able to, walk in a normal fashion after a period of time when the sensations had also recovered. So, but then there are certain situations where it may not be possible to reimplant because of the extensive injuries. So as in this particular girl who was an engineering student and had lost both her arms in an accident. So this case was operated upon by a plastic surgery team from Amrita Institute. And you can see that this young girl has got both her limbs back by hand transplantation, which is taken from a brain dead person. And then, there are certain issues with the hand transplantation because they have to take the immunosuppressant drugs throughout their life. But then it is probably much better than having just a prosthesis, because the hand prostheses are usually not as good as the lower limb prosthesis may be. So now coming to the crush injuries of the extremities. So I'm sure that any of you will not imagine that these kind of injuries, they will be salvageable. And you will be surprised to know that all these two hands and the two limbs which I have shown, so we were able to save these limbs and make them functional at the end of the day. And that has been possible only because of the microvascular surgery. So this is the first case, where after debridement, we made it a single bone forearm, covered it with a latissimus dorsi muscle flap. Here we joined the thoracodorsal vessels with those of the ulnar vessels here, and then the skin graft was put over the latissimus dorsi muscle. And you can see that he was a farmer, and with this hand, which we were able to reconstruct with microvascular surgery using a free clap, he was able to perform all his duties of a farmer. He was able to drive his motorcycle. He was able to work in his farm, and he was able to take care of his animals as well, which he had kept in his farmhouse. And this is another female, young female, who had a crush injury of the forearm. And initially we put latissimus dorsi and the serratus inferior muscle flap here in order to cover all these bones. But since these bones were highly devascularized, so these bones ultimately sequestrated, and she was having a very limp limb. So though we were able to save her limb, but it was not of much use. So in a second surgery, then we used fibula again in this case and made it a single bone forearm. And you can see that now she has got married and she is able to, do all her household work with her right limb, which at one time looked like that it may not be possible to save it. And this is the story of a 11-year-old student, who had gone for a school trip, and the bus, overturned and had an extensive injury to his right upper extremity. As you can see, this is the shoulder region and this is the hand. So whole of his, starting from the shoulder up to his hand, that was badly damaged. So, but he underwent a lot of reconstructive surgeries. In fact, a total of about 17 surgeries were done for him. Here latissimus dorsi muscle has been used to cover it. And then his forearm was again, reconstructed using fibula and the muscle flap and the skin flap. And then later on, he underwent a lot of other reconstructive surgeries in the form of nerve grafting, opponentsplasty, osteotomy of the vascularized fibula, which we had used to reconstruct his forearm. But at the end of the day, you can see a limb which was like this. With the same limb, he was able to write very well. He was able to drive a two-wheeler, and he was able to drive a four-wheeler as well without much of a problem. He's now, a chartered accountant and is working very well. And in fact, he is now more concerned about the cosmesis, and for which again we are helping him by doing some fat grafting and some laser treatment so that the appearance of those scars can also be improved further. So this is, you see this limb, this limb when actually this girl, a young girl, about 23-year-old girl, was working as an IT professional in Delhi and had gone with her friends, on motorbikes to Leh Ladakh. And on their way back, they had a very bad accident. And this is how she was brought to us. There was a lot of soft tissue defect which was there. A lot of bone was lost. But after we had done the debridement, then we thought that we can probably try to save this limb. And what we did was again, a vascularized fibula flap along with a muscle, with a skin flap, and we were able to put it back. And this area was skin grafted, and you can see that the fibula has been used to take care of the lost bone. And this is how it was. This is a Elizarov this fixator, which has been used by the orthopedic surgeons to have the bony union. And now this girl is able to walk on this very leg, which at one time looked like that we may not be able to save. And she's pursuing her further studies in US right now. So this is another patient, very badly crushed injury of the foot. And after debridement, we covered the whole area with the latissimus dorsi muscle flap. And you can see that this functional foot that has been reconstructed, and the patient is able to walk on this foot very well and lead a near normal life. Now, coming to the trunk and the genitalia. You see, this child, had a roadside accident, and not only his whole of the arm that was, avulsed completely, but a part of the chest wall as well as the also came out with it. And you can see here that the pleura is exposed, and you can see how the pleura is going inside. So now the challenge in this case was that there was no way we could, put this limb back, but the challenge was to save the life of the patient. Because with the lungs exposed, there was a great danger to the life of this patient. So after doing the debridement, we just went and did a large anterolateral thigh flap. This is a flap which is taken from the thigh along with the descending branch of the lateral circumflex artery, and which was anastomosed to the facial vessels here. And we were able to cover a large part of his chest with this flap, and the rest was covered with the skin graft. And, though it was not possible to save, reimplant that very badly injured limb, but we were able to at least save his life with, using a microvascular surgical techniques. And this is a patient who had high voltage electrical burns. And you can see that a large part of the abdominal wall that had to be removed, and the gut was coming out. The gut was also gangrenous. That gangrenous part of the gut was taken out by the general surgeon. Anastomosis was done. But now the challenge was to provide a cover because you can't keep the gut exposed completely. And this cover was provided by, again, latissimus dorsi muscle flap, which was anastomosed to the deep inferior epigastric vessels here. And we were able to save him from this. And this is again, he was almost a 17-year-old child who had a very bad roadside accident. And he didn't only have an injury to his right lower limb, thigh, foot, but he lost his penis also, during this accident. And now, he's a young fellow who has to lead all his life. So we reconstructed the penile. We did the penile reconstruction using a radial forearm flap. As you can see here, that a large amount of tissue that has been taken from the forearm, and we have reconstructed the urethra, and at the same time the shaft of the penis also. And now he has got a reconstructed penis where we are planning to put a silicone implant, and I think he will be able to have a functional organ. And I'm sure most of you know that the plastic surgeons do deal with the burns, and we don't only deal with the acute burns, but also with the post-burn deformities. As far as the management of acute burns is concerned, so I think a lot of advancements are there. We are using homografts, we are doing tangential excisions and covering it with the combination of autografts and homografts. And then there are a lot of artificial skin also available. And with this, it has become possible for us to even save the patients with the large percentage of burns. And like this patient was having 65% electrical burns. And, by doing the excisions and the grafting, we were able to save this child, though in the earlier times, anybody having more than 60% burns, we were always finding it difficult to save them, save their lives. And these are some of the deformities, which primarily occurs because these burns patients are not dealt with properly in the beginning, and that leads to very severe contractures like this. He was about 21-year-old man who had burns during his childhood and has never been able to see up. He was always seeing down. He was never able to take his arms up. And this is all because he was not treated properly. If you just allow the wounds to heal on their own, so that leads to a lot of contracture. So skin grafting has to be done at an appropriate time, which was not done. But then later, when he came to us, we released all these contractures, and after a gap of so many years, he was able to see up and he was able to lift his arms also, and then certain residual deformities were to be taken care of later on. So this is another patient, who had electrical burns and lost a lot of tissue from here, not only the scalp tissue, but lost the bone also. This is a skin graft which is lying directly on the dura. So, which is very dangerous. There can be anytime injury directly there, and can lead to a lot of problems. So we put a tissue expander over here, as Dr. Khazanchi has already shown the use of tissue expander. And then we removed the scar as well as the skin grafted area, and then reconstructed the skull with the split rib grafts. You can see here that this is the rib which has been used after splitting for reconstructing the skull, and then over that we used this expanded forehead flap, and we were able to reconstruct his skull as well as the scalp also. And this is a case of acid burns, and where after removing all the dead tissue, we had this granulating wound which was grafted. Then she underwent reconstruction of the eyelids in order to avoid any opacities in the cornea, which she had already developed to some extent. And then we reconstructed her nose also, because her nose was totally gone, and this was again done with a radial forearm flap using microvascular surgical techniques. And this is similar, another patient, where we excised this whole grafted area. He was also a case of electrical burns, and put an expander here and covered all this area with the expanded flap. Now he had a loss of ear also, and in order to reconstruct this ear, so we made a template of the ear from the costal cartilage. So this is made from the costal cartilage. This was put into the forearm, kept there for some time, and then we raised the radial forearm flap here based on the radial vessels and reconstructed his ear. So this is initially, he's still having a lot of edema, and I think over a period of time, this is going to settle down, or we may have to do some bit of some secondary surgeries in order to give him a normal looking ear. So this is a patient, which has been operated upon by one of my friends from Nasik, Dr. Rajendra Nete. And you can see here that she had almost 55% burns, but after the burns had healed, after all the grafting and all, this is the kind of an appearance she had. So initially, it is very important that you must release these ectropion in order to, protect the eye from any opacities, and she was able to close her eyes. And her neck contracture had also been released, and but still, she's a young female, and she was, of course, very upset with the whole thing, because she could never, be socially acceptable with this. So now, in this case, what he has done is that he has used a prefabricated T-dap flap from the back. So this is where you put a tissue expander, and the T-dap is the thoracodorsal artery perforator flap, which was raised from there. The advantage of using tissue expander is that you will be able to close this area completely, and also you can take a thin flap. This prefabrication, I don't think I have the time to explain everything about that. But so we had a large flap available, and this whole large flap was used to cover her face, and then later on. So he reconstructed her nose also using a costal cartilage again, and here the costal. This is for ala, this is for columella, and this is for the dorsum. And you can see how she has changed from hair to hair completely with the use of this flap. So the other option in these cases is to go for a what is face transplant. So face transplant has not been done in India as said yet, though I have shown you earlier that the hand transplants have been done. But then the face transplants and the other transplants has a lot of problem of immunosuppressant drugs being given throughout their life. So if you can reconstruct it this way, I think it is much better than what she was having earlier. So in addition to these, we do reconstruction of the pressure sores, diabetic foot ulcers, venous ulcers, trophic ulcers, ischemic ulcers, and post-radiation. All kind of wounds, they can be taken care of by the plastic surgeons by using various techniques. You may use grafts, you may use flaps, you may use other advanced wound management techniques. So I'll not go into the details of that. But coming to the congenital deformities management, one of the common deformities taken care of by the plastic surgeons are cleft lip and palate. And these are some of the cases which I'll show you that how they look before operation and after operation. So this is just an operation which is carried out in about 45 minutes to 1 hour, and you can totally transform the appearance of these children. And as you can see in some of these pictures before operation and after operation, this is a case of bilateral cleft lip. This is a palate. It's very important to repair the palate at the right age so that they can have a normal speech. And then many of these will need rhinoplasty also later in order, because they have the nasal deformity as well, and which is done at a little later age. And if Dr. Khazanchi has also already shown you some of the orthodontic surgery cases. So in cleft lip and palate cases, there is a hypoplasia of the maxilla. So you can bring it forward by doing the orthognathing surgery, for which you have to do a lot of planning and take the help of the orthodontist also. But this really transforms their appearance to a great extent and builds up their confidence. And this is an example of the bat ear, which is again a congenital deformity in children, and which is very, very depressing for them because they are teased in the school. So again, with a daycare surgery, which just takes about an hour or so, you can correct these deformities and make them psychologically quite stable. And some of the patients, they may be born with the absent ear, or just a little bit of ear, which is not of much use except the lobule, which can be used. And here, this is the costal cartilage, which we have taken to make the ear cartilage template, and which has been used here in order to reconstruct the ear in this patient. So, and then congenital ptosis, again, this though is dealt with by the eye surgeons also, but the plastic surgeons also do the surgery for this, which may be done in the form of levator resection or the frontalis sling. And you can see that how their appearance can be totally changed in these cases. This is a patient of torticollis. You can see that she's a young, beautiful girl, but because of this torticollis, so she was quite depressed. But after we had done this surgery, her neck was totally normal. Talking about the birthmark, so she had a hairy nevus which was removed, and then this is a full thickness skin graft taken from behind the ear, which has been used, and you can see that there is a very good color match, and you can hardly notice any change. This is a vascular malformation, which has been excised, and the scar is very minimal, and over a period of time it is going to settle down. And this is a case of another vascular malformation, which can be treated by the sclerotherapy also. And in this case, we have used multiple injections of the bleomycin, and she may require a little bit of, revisional surgery later in order to make her further look normal. And you can see that there is a dramatic change already in her appearance. So in the congenital deformities, another problem which is encountered is that there can be craniosynostosis or hypertelorism, and you have different shapes of the skull which can be there as a result of craniosynostosis. This is what is known as trigonocephaly, and this is a brachycephaly, and this is called a turicephaly, which is tower-like skull, and this is where you can see one side of the skull is not developed, and this is called plagiocephaly. So all these, can be corrected, the shape can be corrected, and these surgeries are usually done in combination with the neurosurgeons. And just to show you one of the examples, so this is a triangular shaped skull, which has been, now made totally into the normal shape. And some birth deficiencies of the hand in the form of syndactyly, clinodactyly, or radial club hand. So they can all be corrected by using the different plastic surgery techniques. And this is a clinodactyly which has been corrected, and this is the extra finger which is there. So you can remove it without leaving behind much of scar. And this is radial club hand, where the one of the bones is that is the radius that is absent, and as a result of that, the hand is deviated to the one side. So this can be corrected by centralization of the ulna. And then, since the thumb is absent in these cases, so you can convert the index finger into the position of the thumb, so that the hand can be made more functional in these cases. And in external genitalia, we have hypospadias, very common problem. which is dealt with by the plastic surgeons again, and you can bring this urethral meatus at the tip by doing different kind of surgeries depending upon the various anomalies which will be there. And these are some of the deformities of the feet, which can again be corrected by using the plastic surgery techniques. So the other area which I was supposed to cover was the non-surgical modalities. Dr. Khazanchi has already talked about the aesthetic surgery, but in order to give the comprehensive treatment to our patients, so we have to have the non-surgical modalities also in our armamentarium, and so that the patients who who do not require surgery or who do not want surgery, so they can also be offered these kind of modalities. And in this, we have injectables, we have energy-based devices, we can use threads, we can use chemical peels, or we can use derma rollers. So this is an example of use of Botox for the forehead wrinkles. After you give the Botox, these forehead wrinkles are totally gone. And similarly, they are used for crow feet, which are again the wrinkles around in the periorbital area. And this is the use of fillers for the lip enhancement. And you can see here that the lip is also asymmetric, and it has become symmetrical, as well as there is a lip enhancement. And here the tear trough deformity is there. If these patients do not want blepharoplasty, so you can always put a filler over here, and then the deformities can be reduced to a great extent. This is an example where threads have been used. Those who have a minimal kind of a laxity, so that can be taken care of during initially using threads or other means, and they can undergo facelift at a later stage in their life. And these are all energy-based devices. This is the intense pulse light, and this is the fractional CO2 laser. This is the Q switch anti-ag laser. This is the diode laser, and this is the radio frequency. So these are used for different indications. Laser hair removal, usually the diode is used in these cases, diode laser. And for tattoo removal, one uses the Q switch anti-ag laser. And for scars, you can see these patients, who had injuries initially, and then they had very, bad scars, and then they underwent the laser treatment. And at the end of the day, you can see that the combination of the surgical technique and then later on use of the laser, that can really make these scars very, very insignificant. And at the end, to conclude, I would like to convey to all the students that the plastic surgery is a very, very fascinating surgical specialty with wide range of spectrum and a tremendous scope for providing innovative solutions to your patients. And the specialty of plastic surgery has a number of subspecialties in addition to general plastic surgery, and you can always choose to subspecialize in your area of interest. Thank you so much.
Thank you so much, Dr. Ravi Mahajan, Dr. R.K. Khazanchi. I must say that my views regarding this field, my views regarding plastic surgery have totally changed, I will say. From a field that I used to think is a field of surgery related to cosmesis to a field now I think is related to magic. This is how it has changed. So from a gone case of a crash injury to a normalized life, this is how plastic surgery can change someone's life. I think all my viewers who are with me for this entire 1.5 hour agree with me that how plastic surgery can change someone's life, and how our views regarding what plastic surgery actually is have changed from the presentations Dr. Khazanchi and Dr. Mahajan have shared with us by taking time out of their busy schedules. Thank you so much, Dr. Khazanchi. Thank you so much, Dr. Mahajan, for being with us. We are really honored to have you. We actually plan to take some doubts in the end, but because of shortage of time, I think many of us are hungry. And I think sir is already taking time out of the schedule, but don't worry, I've personally noted everyone's doubt in my laptop. I have created a doc file. And if possible, we would like to get in contact with Dr. Khazanchi and Dr. Mahajan anytime when they're free. And we would like to address those doubts to you later. So don't worry, we have already, and I think most of the doubts have been taken care in the presentation itself. You can go through it. It's there live on YouTube. It will always be there on YouTube. So thank you, Dr. Khazanchi and Dr. Mahajan. Thank you so much. So with this, if the speakers are free to go, but I will share my screen for the QR code for the viewers to fill in the feedback form, which is important for them to mark their attendance for the event. And I will keep that QR form with on the screen for a total of 30 minutes. So every viewer is requested to scan the QR form and fill the form so that they can mark their attendance. The speakers, Dr. Khazanchi and Dr. Ravi Mahajan, are free to leave. Thank you so much, sir. And we, on behalf of all the viewers and team AMSACON, I would again like to extend my warm regards and and gratitude for taking time out of your schedule and helping us learn so much more about this amazing field of surgery. Thank you so much.
Thank you. Thank you very much. Thank you.
Malika, I think you're muted. We cannot hear you.
Thank you, Anshu. So as I was saying that please scan this QR form to mark your attendance. All the delegates are requested as it is important for you to get your delegate certificate, and the people on YouTube can do the same. We'll keep this form on screen for 30 minutes. In case you're unable to view it or something, you can always let your group moderators or the co-host of this meeting know. Thank you so much for joining us today.
Yes, so for everyone who are requesting, asking for the sign-in picture, you can head over to the AMSA India Instagram page, where you will find the AMSACON filter, and you are required to use that filter and click a picture of yours and upload it to the form. For everyone who are inquiring about the AMSACON filter, you can head over to the AMSA India Instagram page, where you will find the AMSACON filter. Use the filter, click your picture, and then upload it on the form.
Okay, so for those who say they can't find the filter, so you can search for the filter in the AMSA India's Instagram page in the highlights itself. And the easiest way for you can search for the filter is that if you go in the AMSA India stories, one of the EV members must have definitely put a story, and you can get the filter from there itself. Another way to find the filter is then whenever you search your Instagram stories, when while putting your stories, you can search for the filters when in the search for filters option down when you're putting your story. That can also be there. Type AMSACON in the search for filters option and you can find the AMSACON filter. We have more than 3 AMSACON filters. You can choose any one of them. Those who say they don't have an Instagram account, they can upload a screenshot of the session if you had clicked any picture. But those who do have an Instagram account, we request them if they can painstakingly take like 2 minutes from their time and click a picture for us. And those who have done scanned the code, they have filled the form and as well as upload the picture, they can definitely leave the meeting.